Mass Women's for many years, a friend and remarkable person. Susan, thank you so much for offering to lead this important conversation today. I'm going to turn it over to you.
Great. Thank you, Dawn. Thank you for those introductions. I want to reinforce your gratitude to this wonderful panel today that we have here today. This is probably the most important topic in the country, if not the world, today. So really grateful for these busy people for taking time out to speak with us today. And we're so excited to have so many attendees on the call. I know it reinforces the questions, the interest, the curiosity around this important topic. So I'm going to actually begin at a high level. I think it's fair to say that over the last 18 months, we've all become, mini experts, or we think we're experts, correct? In medicine and epidemiology. We know statistics that we didn't know before. We know acronyms that we never knew before. We're following the daily count and hearing. You would have to be living under a rock not to have gleaned some expertise. So I'm not going to repeat the published statistics because our state does a wonderful job at posting that information and sharing it on a daily basis. But I will talk about some of the personal statistics that people feel. So everyone's statistic is personal when it comes to COVID. It's, my child hasn't been in school for a year. My child wasn't in school and wasn't getting lunch and breakfast served that they were being served during the school day. The head of our family, the family patriarch, passed due to COVID. My business passed. My business went under during COVID. My partner was furloughed during COVID. I was feeling isolated and alone during COVID, and that impacted my mental health. I could go on and on and on, but the breadth of this pandemic, the reach of its pandemic on business, on human beings, on families, and on individuals has just been all-consuming. So we're going to dig in on a couple of topics today around this and talk about the role of government. First and foremost, we are a political organization. So we know that pandemics are predictable. The science tells us they come, in a mild form every 30 to 35 years. The big ones hit every 100 years or so. What's unpredictable is when they will come. So we have to plan for these proactively, and then we have to manage the situations when they occur. So I'd like to, with that framing, I'd like to direct the first question to Representative Gouveia and ask her, Representative Gouveia, help us think about the role of government. What role does government play in a public health emergency and crisis such as this? It's kind of a two-parter. So that's kind of the big question. And then maybe, if you could dig in a little bit on, there are a lot of tensions here, right? How does government balance this role of those individual data points that I was mentioning, keeping individuals safe while balancing the needs of the economy and the larger community?
Sure. Well, thank you so much, Susan. Really appreciate you facilitating our panel today. Thank you to Dawn and Macy and Kat at MWPC. Really just honored to be here with all of you today. To answer your question, so the way I see it is government has not only the accountability and responsibility, but they also have the authority to act in the face of, quite honestly, any public health crisis. And this comes under very well-established law, police powers that's embedded within our public health infrastructure. So that's something that is, I just think, really important level setting for everybody, is that it is something that public health officials in every single community, in every part of the country, really already has this, as I said, opportunity, responsibility, and the authority to act and to respond. The way I see that kind of playing itself out a little bit further is I think it's critical for government leaders, both at the local, state, and federal level, to be incredibly honest and truthful when it comes to helping the public understand and to empower the public to protect themselves, their families, and their communities in the face of any public health crisis. Whether we're talking about gun violence, we're talking about systemic racism, those are both really pressing public health crises, the climate crisis. It's really, really important for government officials to be truly as upfront and as honest as possible without creating panic and without creating chaos, but just so that people can take those measures to protect themselves. And so as it relates to COVID, as it relates to your second question around how do we kind of get our economy back open and keep our schools open, there are ways that we can do that safely. It's really, quite honestly, we should have had no discussion around a mask mandate for unvaccinated children in schools. That should never have even really been anything for us to have debated. It should not have been punted to school committees, because school committees are volunteers that are really working on trying to make their schools as safe as possible. They are not public health experts. They certainly have access to local public health experts in their boards of health, but still think that that's something that should have been taken up at the state and the federal levels rather than punting down to the local level, because we really saw neighbors pitted against neighbors. So I think that really backfires, those kinds of getting too ahead of ourselves, getting too excited about, oh, yay, we're on the other side of this pandemic. We're getting the vaccine. We can all go out and do the things that we used to do. Public health experts have known since the beginning of this pandemic, if you asked any true infectious disease expert whether or not we could, start to run around and do the things that we used to do before COVID hit us, they would have told you no. And they would have been a little bit more cautious than what we saw coming from the federal and our state levels across the country. As it relates to opening our economy safely, I think what we really need is those mask mandates. It's certainly in our school environments. I think the guidance from the CDC around wearing masks when you're indoors is great. I think we ought to really be moving in the direction of probably mandating those in certain situations. Certainly the vaccines, we could talk a little bit about vaccine passports if people want to. But the other piece that I find that's truly missing is having the right kinds of testing regimens in place as it relates to getting our economy back open and keeping it open and keeping our schools open. And what I mean by this is we have been so focused on the PCR test, and what we really need to do is make sure that we have access to free rapid antigen testing so that families and individuals are not forced to go to Walgreens or CVS to shell out $40 for rapid antigen tests. Those are things that we should be able to get access to at our local library or at our local housing authority, our place of worship, places that we're already going in our daily activities, and they should be free. So that's how we can do both. I never really saw the debates around our economy and our schools as mutually exclusive from protecting our health and well-being. So thank you for the question.
Thank you. That was incredibly helpful. And I see our clinical people nodding, in agreement with much of what you've said. So I'd love to hear from Dr. Van Alphen and from Chris on, when things are not behind us by any means, what do we need to, I saw you nodding about free vaccination, Dr. Van Alphen, like what have we done really well that we need to build on, and where is there opportunity for us as, we go into 22, 23, what's ahead?
Susan, thank you so much for inviting me. And I couldn't be any more thrilled and honored to be with this amazing group of not panelists only, but also everyone who's attending. I'm just thrilled. So I couldn't thank you enough. And thank you, Kat, and everybody else for organizing it. I'm a psychiatrist by training. So Susan, you said so much and I felt like I was hearing myself. All of a sudden, mid-March, we started wearing all of these hats. Now, all of a sudden I had to manage employee health, and all of a sudden I had to be the medical health expert. I'm a psychiatrist, an epidemiologist, an infectious disease expert for all the 10,000 individuals that we serve and the 1,000 employees who work with us. And then we had to go from learning about, 20 different types of fabric when it comes to, cloth masks and what is the difference between K95 and N95. So, and all of this in the midst of being a young mom with 2 little kids with no daycare of school. And still figuring out, how do I make myself be heard on Zoom and knowing when I'm not muted. So I'm sure not to go more into the personal note, but I truly appreciate you, Susan, sharing that with me. And I would imagine everyone in here has some cute stories and a lot of sadness and a lot of loss. So yes, there has been loss. And from that perspective, I would say in the community, let's just recognize it. I think accepting what it is, and as Representative Gouveia put it so well. Unfortunately, medical experts, the healthcare community started seeing this as something that was going to be dark if early intervention was not going to happen very, very soon. You all remember probably in late March 2020, we all heard about what was happening at the soldiers' home, and how devastating the loss of so many veterans, and how things were known but were not being spoken for a while. And that was one of the things that we as an executive team were meeting 7 days a week, of course. And I remember still thinking, we have 43 residential group homes for almost 300 individuals with serious mental illness, substance use disorder, and or developmental disabilities live. How are we going to keep people safe? How are we not going to be the next organization ending up on all the news headlines and on the newspapers because we don't have testing? We didn't have clothing masks. And if there is a lesson I have learned from what we did to make sure that we kept both the people we serve, but also our staff safe, was going back to the basics. And our first question was, when there is a snowstorm, everybody knows what to do in Massachusetts. And we all know what happened in Texas when there was icing on the street. They were just not used to it. But last time we had a big pandemic was 100 years ago. And that's actually what we did. We said the best way to keep people safe is to literally close the doors and have people stay in. So we actually did a huge financial investment, which we know was not going to be sustainable, but it was truly to stop the bleeding. And for almost 2 months, I would say 75% of the residential treatment programs had no foot traffic. We paid our staff who jump up the gun and were willing to do it. And that's the community spirit, to stay and live in group homes with the patient. God, was I scared what that was going to look like. And that was the most positive outcome I have heard so far in any congregate care setting. The only persons who tested positive were clients who had actually encountered COVID before moving into a locked unit. So again, if I think moving forward, and Susan, I have a lot of positive hopes, and I do see the light of the tunnel shining bright. Let's go back to the basics. Community, go back to mission-driven organization. What are we here for? Is to serve our community and to also serve our employees. Our employees are part of the community. Yes, we can talk about PPE. Yes, we can talk about access to testing. That all should have, could have, would have. I think moving forward, having those basics in mind is going to be a first way to get started. The second thing we did is we really reached out to every single partner. We were humble enough to say, just like everybody else here would imagine, we need help. This had to do working with Beacon Health Options. This has to do with Mass Health. This has to do also working with our partners, Mass General Hospital and other larger healthcare systems. I literally begged for masks. I literally begged for different types of PPE. Also working with a local police officer, and also working and collaborating with other organizations like Quest Diagnostics. I still remember, again, in that soldier's home when I said, I need 20 COVID tests. Could you please get me 20? And I heard, I'm going to give you 40 Mignola. So again, I don't want to do a parallel with the snowstorm because the snowstorm hopefully lasts just a few days, but it goes back to the basics. What do we need to keep people safe, and also being aware that things will take a large financial investment, but the life of the people we serve and the staff who work with us, I think it's much more important. And I have to be very thankful to both the state of Massachusetts and also the federal government as far as the financial aid that came to organizations like ours. I also know that financial aid for some other organizations like mine, whether we're large or smaller, did not come early enough. So a lot of people had to be let go. A lot of people had to go in furlough. We were fortunate enough, and I'm very grateful to our leadership and to every community partners who work with us. But that was another stop. When should financial aid come, and who should it go first? We have heard a lot, we're headquartered in Chelsea. Chelsea was hit the worst, had the same incidence rate of new cases of COVID as New York compared to the state of Massachusetts. Yet when vaccination started, Chelsea was treated just like any other community. Just starting to think about where do we start providing help, and thinking about parity also, how do we proportionate that? Should we just go with same number for everybody, or should we be mindful of which organizations are actually being hit the worst? We will talk more about daycare, but my children's daycare, and I imagine everybody's daycare or teachers, did not get vaccinations are very, very late on. And a lot of our health workforce did not come to work because they had nobody to leave their children with. So again, I feel like this has been devastating, and it still is, although less than it used to be. But so much I think we have learned. And as you put it, Susan, I feel a lot smarter about how to manage a pandemic today than I have ever felt in my life. So those were just few of my experience that I wanted to share with everybody. And I'd love to hear Stephanie or Christina or other panelists for that matter.
Yeah, great. Chris, why don't you tell us what, you would love to see things through your lens. BMC, my alma mater, I worked at the BMC health system, serves some of the neediest people in the city of Boston and really in New England. It's the largest dish hospital, disproportionate share hospital in New England. You see very complex cases because of the role of what's not in people's lives. So how have you approached things, Chris? How's BMC approached things? What have you seen?
So thank you for inviting me. I'll try to, I have a little list in my head. So getting to the PPE and infection prevention, when we first started, we were working like 16-hour days just to train everyone. And because of the shortage of PPE, along with medications, different things that we weren't getting a hold of, we had to pivot a lot and start saying, okay, if we can't use this, what can we use? And, given that everybody was trying to get certain things like tests, like Manjola said, and things like that, we need to literally daily, we were changing our protocols. So I think we can build on that. I think that, that caused some mistrust, but I think going forward, if we have policies and procedures and protocols in place, because the shortage on supply is not going to go away. We see it even with air conditioners or pools or different things like that. We know that there's shortages throughout the supply chain, and it doesn't just happen to the medical field. But when you don't have an antibiotic and you need to pivot for what one are you going to use, or if you don't have albuterol, then that's a problem, especially when you're seeing COVID patients. So I think that just having all that information, and we could actually improve and build on it. The other thing is the shortage of beds. We saw expansion throughout the hospital, that we were going into areas that were outpatient, procedural. We just didn't have enough beds. And we actually see that today. I don't know if it was the delay in people coming back into getting care, but we are short on beds. So as we see COVID start to creep up in the hospital, we need to think about that and create more bed space. In terms of looking at people that are admitted too, we need to become smarter and innovative with, perhaps they start doing things at home like IVs and certain procedures like hemodialysis or some kind of wound thing, that they can get the antibiotics at home. So we need to think about those things, or discharging people smartly, that they're not coming back and that they can have care outside the hospital so we can free up beds. Another thing that we are facing, and it's unfortunate, is a nursing shortage. And the nursing shortage is throughout the United States. There are people that are leaving, becoming traveling nursing because they're getting paid quite a bit more than they get these bonus checks, and they're saying, hey, why not travel? Unfortunately, that's leaving us with some shortages. And it's difficult when you're caring for patients, when instead of having 3 patients, all of a sudden you have more. I think BMC has done a really great job in getting the staffing, but we need to start to think, how can we, and people are tired, people aren't getting vaccinated, and the nurses are very tired, and the medical staff itself. So, I mean, that's like twofold. Like, you think to yourself, okay, how can we get these people vaccinated? Well, there's a mistrust with vaccinations. And it goes to say, I mean, I had to convince people of color and of different diversity within Boston Medical, people that I work with, that the vaccination is a good thing. Now it's being mandated, and by October 15th, if you work at the hospital, you have to have a vaccination. So just getting those people comfortable with vaccinations and gaining the trust of the community. The other thing is, I think that we need to build on outreach programs. Definitely, we need to, people are still going to be scared to go out of their house or scared to go to a facility where they could get exposed more. So just to do those outreach programs. And then lastly, investing in cures trials, we need to do investment there. I was reading something, Delta, Alpha, Beta, Gamma, all the different variants. It's because these variants are popping up because people aren't vaccinated. So the virus gets smarter and they do. And so the people are getting the variants, they're more contagious and they're getting sicker. So that does not help the situation. So we can expect more variants. So we need to invest in the cures and the trials. One thing that I think that I would, looking back differently, would have been that maybe to employ telemedicine earlier on, because a lot of people deferred their care, and that was not a good thing. So I think most people have cell phones. I have to say, being in the hospital, myself, my colleagues, being on the floor, at one point we all got tested because we felt like, oh, we have COVID, right? And, or, you know, we couldn't see a doctor. So I had a big rash on my face and I had to go through dermatology, and they were looking at me saying, oh my gosh, Chris. But I did it through telemedicine, and that telemedicine appointment was just as good as being in the hospital for me. I'm not saying everything has to be telemedicine, but we have to use those avenues because we need to be able to care for the people and not let them defer themselves for their care.
That's great, Chris. Thank you. Thank you all. And so I'm going to do a little recapping here, because if people have questions, maybe Kat will jump in after my recap and tell people how they can use the chat function on the questions. But before we move on to the next piece, I want to make sure I've kind of captured or maybe synthesized what I heard. Maybe it's what others have heard as well. And, you know, we thanked the three of you for participating in this panel. But as I hear you all speaking, I feel like we also owe you our gratitude for being on the front line in the ways that you are as direct caregivers and serving in the legislature. So thank you. I know you have had an exhausting 18 months. Dr. Van Alphen, you know, I kind of had chills, you know, had goosebumps on my arms thinking about people moving into those residential units and, you know, the hardship that was for them personally and their families. You know, that's incredible. It's I think a hallmark of our country that people come together at times of crisis. Chris, you know, hearing the nurses work 16-hour days is, you know, that's heroic. And Representative Govea, I know the legislature has been working tirelessly at this. I heard you talking about your 7-day-a-week conversation. So thank you for that. But in terms of where we've been, I'm hearing leverage the authority, the legal authority we have to get done what we need to do. Go back to the basics. Just, you know, this is new, and figure out, you know, like what are the most fundamental things that we have to do, and that will guide us there. Leverage community, leverage, you know, the resources in the community broadly, and kind of hand in glove with that is be creative. We've seen a lot of creativity during this. That's, you know, going to the fire department, investing in leveraging telehealth, Chris, as you have said, and invest broadly, invest those federal and state funds wisely, because we're not done here and there will be a recovery period following that. And I think an ongoing vaccination campaign sounds like it's, you know, crucial to, you know, kind of the long haul of getting out of this. And then I guess our North Star, which you know, you all really helped highlight for me, our North Star should be keeping people safe, you know, physically safe, their mental health safe, well-being should be taken care of, and their financial and economic security are things that should be like, if we use that as the North Star, it's a pretty good, will illuminate a pretty good light for us to follow. Okay, so I'm going to shift gears a little bit. We talked about clinical implications, and I do want to drill down a little bit deeper now on the disparities that we've seen during COVID. You know, what a unique period of time. I've read in the literature the expression of the dual pandemics of COVID and racism colliding. And, you know, COVID really has identified disparities in the health system that we have been aware of for a very long period of time. But boy, there was a bright light shined on it during the last 18 months, because we have seen greater disease burden in communities of color and underserved communities. So would like to begin, with the clinicians on the panel and ask you from a clinical perspective, like what is driving this? Why is it that we have these health disparities? Why do we have these gaps in our systems? And what can we do about it? And then Representative Gouveia, I'd love for you to react to that and, weigh in as you see fit.
Okay, I can start on this.
Thanks, Chris. Thank you for that.
Yeah, sure. So like I said, I work with a very diverse population, and some of them were very scared about getting the vaccination. And I'd be like, why? And they're like, well, Chris, I don't know what's going to happen 3 or 4 years down the line. And then you hear like people that are pregnant or that want to have children, they're afraid of infertility. There was a definite scare. And, I go back in history and you think about and they talk about it, like the Henrietta Lacks case when they were totally, or the Tuskegee, the syphilis situation there, where they thought they were getting treated and they weren't. Big experiments. So I think history plays a part, and people think what happens in history, it plays again. So I think people are scared. I also think, there's a lot of people that have a language barrier, and to the extent when they're being explained something, they need to be explained in their language and for their understanding, like culturally. I think that we need to address that more so, because to convince people, not to based on the evidence, that things aren't, you can get the vaccination if you're pregnant. You shouldn't have to worry about the infertility coming down the line. But also, I will say that, some of these people might not have a reading level too. If they're reading something, their reading level might be a little bit lower. I mean, oftentimes poverty plays into it. You're poor, you don't have the means to have a higher education. It kind of goes from there. Then you're limited on your work options. You're working in a lower level where it's paycheck to paycheck. Oftentimes, some of the people that we work with, they're living paycheck to paycheck. They can't take the time off to see a doctor even, or, they're essential workers. Those are the ones that have to go into the hospital, and they're the housekeeping staff. They're the ones that do the transportation and the CNA that are working side by side with the nurse. In addition, they're the ones that are in the grocery store. So a lot of those people are at higher risk as it is. And if they're not getting vaccinated, that just puts them at such an increased risk. So I don't know if I answered your question.
No, that's really helpful, Chris. And before I hand things over to Dr. Van Elfen, I want to comment on, you referenced those, the Tuskegee trials or study. And that's I think you're referring to the study in Alabama. I think that was 40 or 50 years ago. It's, really a dark stain on our history, really on the history of science, where Black men were enrolled in a study on the treatment of syphilis, and they were not given medication. And during the course of this multi-year study, the medication became available and it was not provided to the men in the study. And so oral history for years has passed along this story, this actual story, and what occurred and the lives lost to this. And that would create distrust in anybody.
Yes, I agree. And they do speak of it, the history.
Yes, great.
Thank you.
Yeah, thank you. Dr. Van Elfen, I saw you nodding it many times.
Yeah, Chris, it's like you're you're reading my mind, and you put it beautifully. I couldn't agree more. And I'm just going to piggyback on what you said, Chris, just a couple of things. If we start, for instance, again, I'm taking Chelsea as an example because Chelsea has a majority of Latinx population, a lower percentage of African Americans, and the rest is Caucasian. If you think about why was this city hit so hard, harder than any other town in Massachusetts? And, we all were scratching our heads because we're on Broadway, that's home for us. And I've been thinking of course, there's been a lot of writing over the last, since April 2020. And it's interesting when you start to look, and again, It's basics, but basics from what perspective? For instance, apparently I found out to my surprise, 81% of the population of Chelsea who is in the workforce actually is in the essential workforce. So as Chris was saying, these are considered essential workers who actually have to be on the front line and work. So that already puts them at a higher exposure, at a higher risk for exposure and contracting the virus. The second piece is that having a much lower socioeconomic level, they also are more prone to using public transportation. There goes another exposure of what that increases, another factor that increases the risk of exposure. Another very important factor has to do with the density. Chelsea, the density of population in Chelsea is 3 times that of Boston. That means that you already are 3 times more likely to live in a family that looks like a congregate care setting where spaces are much smaller, but the number of family members who are living under the same roof is a lot higher. That means that if someone tests positive or has symptoms, there's no way you can isolate and go anywhere. So that probably will be, it's another reason why at some point, every 10 people tested on the street, at least 4 were testing positive. Others have to do also with earlier factors that I think make populations like Chelsea, not just Chelsea, but also like Chelsea, more prone to just general having poor health outcomes, and also lower access to care. Not only the lower socioeconomic level, think about where Chelsea is geographically located. You have Tobin Bridge and you got the airport on the other side. Right. That already puts you at a cardiorespiratory higher risk of disease. There's a large population, there's a good percentage of the population that are immigrants or illegal immigrants, or in any way, shape, or form might have a lower access to health insurance or health insurance that allows them to access both preventive care and also acute care. On top of everything that Chris said, the fact that a lot of medical information or clinical information is not available in their native language. And even if it's available, is it being provided in a culturally sensitive modality? Like that's probably one of the basics foundation, again, moving forward. It wasn't just to say the clinic is open. We actually had to put it in a way that it really resonated with how they think of the clinic. The other piece is, who are the influences in these cultures? It's not the medical doctor. As you said, Chris, it's not going to be people like me who did research, because history has not put us in the spotlight. So that has been another lesson learned, reaching out to a lot of vulnerable populations, if you will, influences, and trying to work with them and get them on board. But that is only one part of the story. That tells us why we're this a racial minority is more likely to get COVID, but also to have a worse outcome from COVID. And then we go to vaccinations. Like I said earlier, certain populations got their vaccines a lot later, and it was not delivered initially in a culture sensitive way. I was just looking at a recent publication from the Kaiser Family Foundation that finally showed that racial minorities, including African Americans, Hispanics, and also Asian populations, are actually catching up speed with vaccination. Well, why is that? Why is it so late? Why is it 6 months later? Because finally we are providing information in the language, in a culture sensitive way, and we are listening to where their concerns come from. And rather than fighting them, we're trying to work with them and building them. For instance, in our organizations, we have our own pharmacy that provides vaccinations. We are about to open mobile vaccination clinics for both regular seasonal influenza, but also for COVID vaccine. And not just for our patients and clinics, but also for our staff and for other community members. Why? We need to bring vaccines to where people work and where they live. We can't expect everybody to walk into a pharmacy or to a primary care physician. So again, I go to the basics because basics teach us how we can become sophisticated in managing the next pandemic much quicker, much earlier, at a lower cost effectiveness and at a lower morbidity and mortality rate. So those were some of the things I wanted to add what Chris just shared with us right now.
That's so enlightening. Thank you both. Representative Govea, do you want to weigh in here? Because we just heard from Chris and Dr. Van Alphen on, really the care aspect of this, but I think we all know there's there's the economic infrastructure of the way our state is organized, the way services are organized and available to people. What thoughts would you like to share?
Yeah, there's a few thoughts. So for me, this the situation, both in terms of infectiousness and the spread in our gateway cities, our communities of color, and our low income and immigrant communities reminds me a lot of Katrina, and just the images that we saw of particularly African Americans sitting on their roofs waiting for help to arrive. And the reason why it reminds me of what we're contending with as it relates to our pandemic response, whether it's in terms of the infection rates or in terms of vaccine access, is it's because we know that there are specific populations, whether we're talking about here in Massachusetts or any other place in our country, where communities of color, low-income communities, and immigrant families are excluded from having access to a lot of different things, particularly information, accurate information, because they just tend to not be brought in by those who are in leadership positions in terms of helping to make decisions about vaccine rollout or how to message specifically around how to protect yourself from the spread of COVID. I believe and agree with everything that Dr. Van Alphen just said about the density and the fact that so many of our immigrant families and low-income families do work in essential services, so that certainly does put them at greater risk. But there are ways that we would just not really putting the health and well-being of all of our residents at the center of how we made critical decisions. And one that I go back to repeatedly in my mind is the mass vaccination sites, which just left so many people really scrambling to be able to figure out how could they get access to a vaccine because they didn't have transportation, or they didn't have someone who could drive them, or they had children that they had to take care of, and they could not get an elder to a mass vaccination site. Our local public health leaders were ready to put shots in people's arms, but that's just not the direction that our state chose to go into. And so that did mean these pretty significant delays in vaccine access. The other thing is that when you do look at and kind of parse through the data a little bit more in communities like Chelsea and Lowell, and you look at the fact that for certain populations, the vaccination rates are looking really good. They're looking very positive, particularly in Lowell with the Southeast Asian population. The vaccination rates are pretty much on par, and same in Chelsea. And when you kind of dig back and say, well, what's going on there? It's because the organizations that are reaching out to specific populations like La Colaborativa in Chelsea and Lowell Community Health Center in Lowell, it's because they have the trust of community residents. And you can't recreate that on the fly in the middle of a pandemic in key communities where organizations just haven't necessarily built trust with immigrant populations and low-income families, or they haven't had the resources to be able to build trust, or they don't have the outreach staff to build those relationships. So one of the things that I really hope we do coming out of this pandemic, and I'm a social worker, so this is where I'm putting on my social work lens. We need to invest in those kinds of relationship building and outreach activities, because the trust piece is the biggest component. And, Chris said this too in her remarks about, hesitancy around getting the vaccine, not trusting it because of Tuskegee and other ways that we have really, put the health and well-being of populations at high risk and cause death among people. That is going to continue to be something that I think we're going to, have to contend with. So those are the ways that I respond to those questions around disparities and just thinking about the systemic issues and what might be the lessons learned and the opportunities for us moving forward.
Great. That's wonderful. Thank you so much, Representative Govea. And I see a shout out to social work power. So that's awesome. And it kind of synthesize what I just heard from you. And a lot of the same key words the three of you articulated. We have history to correct. We have to build trust in our constituencies, build trust in the people who need the services. That requires cultural sensitivity, understanding the language and the idioms, more, not just the language, but what's important to individuals. And, adapting, kind of really rethinking the way we're doing things. It might not be so much an adaptation, but is there a different way to be more effective in reaching people that need services? And we need tailored solutions. And invest in relationships to kind of build that trust and really understand the needs of the people in this wonderful Commonwealth. So again, kind of the same things that I think, if we keep the North Star as the people, the communities we're trying to keep safe, that leads us to where we need to be. So great discussion. And I can see the time is slipping away here. So mindful of the fact that the word woman is in the name of this organization, MWPC, I do just want to shift to women in the workforce. Chris talked about a nursing shortage. We've probably all read about the numbers of women that have been leaving the workforce in connection with COVID, really record numbers, and they're leaving the workforce at a rate that exceeds men leaving the workforce. People are doing it for a variety of reasons. In some cases, it was for home child care. In other cases, like this has just been such a dramatic situation for our country. It's been a great inflection point for many people deciding, what do I want to do? I think, I've read about the great resignation, the term, the big quit. People are leaving the workforce in droves. And with so many women doing so, that really has the potential to set women back on professional advancements that we have made, both in terms of salary equity and advancing to the top branches of organizations. So, interested in knowing, are you seeing that in your own organizations? Representative Govea, do you have thoughts on what we need to do to make it easier for women to stay in the workplace, and women who want to stay in the workplace and advance their careers? I think you're on mute.
I think quite honestly, it's going to take time for us to see the numbers come back. I think that's just a reality that unfortunately we have to face. And that's because of the childcare issue that we already had a shortage back in 2019 of 25,000 to 30,000 childcare workers. So what we need to do to get women back to work is to address the childcare issues that we already had before the pandemic and that have only been further exacerbated. We know that we've lost about half of all centers across the state. The other thing that kind of comes to mind as it relates to childcare is making sure that it is much more affordable, that people who work in childcare centers, that they are paid at a higher wage and that we are reimbursing, and that the government is making investments in childcare as the common good that it truly is. And part of what's going to be needed with this is some flexibility. So now we know that around 63% or so of businesses that are able to do hybrid interactions and hybrid work are probably going to move in that direction. And what that might mean then is on some days you may need childcare in the community that you live, and in other days you might need childcare that's closer to the place that you work. And so there might be some needs for some of that level of flexibility, but we just know that we need to make those investments in childcare pretty immediately in order to get women back to the workforce. Oh, I think you're muted now.
Great. Thank you for the prompt. Any say the issues the same in clinical settings? Women?
Yeah, and I just very quickly I couldn't agree more with Representative Gouveia. We just recently did a survey of our organization. I'm part of a real estate committee. We're trying to think if we should, we have all of these little buildings and there's no parking anywhere. And it's like, let's start with the basics. What do our employees want? And one request that was anonymous was daycare, daycare, daycare. Yeah. I know in 2012, when I was working in Chelsea as a psychiatrist at that time, and here I am having my first child, there was a daycare across the street. And all I could think of, wouldn't that just be wonderful? I couldn't get there, but I remember how wonderful that the idea of having daycare across the street. Yeah. So I couldn't agree more about daycare. What I would add also is that, and again, I can speak from personal experience, but also we have lost some very high quality physician and nurses and nurse practitioner who did not leave us to get another job. They left us because they just wanted to cut down on hours, and it wasn't just because of the pandemic. They actually saw a different way of living and of working. And definitely we as an organization, I think all together, rethinking the workspace, but also rethinking care modality, but also working modality, and being open-minded to that, it's a sine qua non for moving forward and for retaining high-quality talent. And last but not least, I'm very proud to be part of a women-led organization where 3/4 of our senior managers and executive team are actually women. So I feel very privileged, but I know that this is a rarity. So going back to creating channels very early on, not after people graduate from college, not after people are hired, but actually from elementary school, middle school, high school, creating channels for women where they truly have opportunities and access to actually getting not just an advanced degree in higher education, but to truly build a career in leadership. If that is what women want, and that's what drives them. So definitely education goes along with childcare, but I think taking it further. We know that education is the #1 factor affecting status of health in the world. So.
Great, thank you. Chris?
I could add to that. On a different note, I agree with everything that was said, though. Daycare was a big factor because the staff here at Boston Medical, when they had to come to work, they didn't really have a choice. So they started some kind of daycare outside of Boston Medical. The doctors and the nurses and everybody got together and it was offered. But that was just at the time. It was kind of like, you know, they needed it. So we did it. It was like at the elbow support there. I know at Boston Medical, we've increased our tuition reimbursement. We actually doubled it, which I think that makes a difference. And we actually hire associate nurses. Usually a lot of these big hospitals don't hire them. And the reason that they're associate nurse, they have an associate's degree, I should say, in nursing, is because usually, you know, a bachelor's degree is much more expensive, right? So they can only afford to do what they can do. And so Boston Medical says, okay, we'll hire you, but we're going to make sure that you get your BSN. So, and they have the thing right there. Another program that they did that I'm really proud of is that they noticed, you know, we're a very diverse population we serve, but leadership wise, we aren't as diverse as we should be. Hopefully we'll get there. But one thing that they put in was in the infection prevention group, they actually only allowed, I should say allowed, but they only had candidates that were minorities. And so we hired 3, and they're going to be 3 leaders right there in infection prevention. So I think it's providing avenues for staff of diversity to kind of come forward and become leaders.
That's great. I love that story on the associate nurses, Chris. I wasn't familiar with that. I know BMC is just passionate about equity. When I worked there, they had an excellent slide that, you know, kind of a great visual to help people understand what equity means. And, you know, on the left, it showed somebody without a bike, you know, running to keep up. And then in the middle column, everybody was given a bike, that, you know, everybody was given the same bike, and that enabled transportation. But in the most evolved model, everybody was given the right size bike for their needs, or an adaptive bike if they had special needs. You know, like for true equity, it's not one, we can't peanut butter the solutions. Like we really need to have these tailored solutions, as we talked about before. We talked a lot about childcare. I happen to take care of my 93-year-old mother. So like there's that end of the spectrum as well. You know, we have to enable people to balance those life needs. And, you know, we have 10,000 people a day in this country become eligible for Medicare. We have an aging population. We need systems that take care of our seniors as well. So I have a question. Is childcare, and this is from Dawn to everyone, is childcare the only topic being discussed at the State House to address the disproportionate impact of the pandemic on women? We know it's a hot one, Representative Govea.
It's the hottest, which is why I highlighted it, just knowing that we're short on time. There are other issues that are being taken up. We know that we need to do a lot around retraining. We have 300,000 to 400,000 people who will need to be trained or retrained over the next decade. And earlier when I said, you know, we know that the impacts on women are going to be long. I don't know if I mentioned that. For women and workers of color, it's 18 months that we will come back into the workforce. Like we will sort of start to catch back up 18 months later than our white male counterparts. And that's pretty significant. So there's truly a need to reinvest more in our workforce training programs. I also think that looking at debt-free higher education, particularly for community colleges, can be a real true pathway to getting women into different kinds of fields. And we also need to look at on the other end, you know, when women take time off, whether it's to care for children or to care for aging parents or to care for a loved one, or just cut back hours to make things work within the family structure, that impacts our retirement. And so taking a look at what are the ways that we can support women's savings and opportunities to have a healthy retirement later in our lives, because we know so many women face poverty, you know, who are seniors. And as Susan said, you know, our population is aging, but childcare is really truly like the biggest issue. And then I know we're wrapping up with something positive, so I have something else that's related to women that I'll mention in the wrap up.
Oh, thank you so much for that, Representative Gouveia. And I love that you called out financial literacy. I know Whittier Health Center in Roxbury does a wonderful job, you know, like that's part of their core services to people to educate them on that front. And I also love that you called out, you know, women will be returning to the workforce more at a later rate, and women of color. And we just had this conversation on equity. We need to always be thinking about that. MWPC is deeply committed to equity. I just feel we're at a time in our world where equity needs to be part of every important discussion. And this is that. And from the get-go, we need to be building policies, you know, not that peanut butter approach that we talked about, right? We need tailored solutions so that everybody can achieve and thrive. So Representative Gouveia, you set me up for, we are close on time. So I would love for each of the panelists to do a shout out on why we should be optimistic. You know, are we rounding the corner? I think there have been lots of, you know, there has been loss for sure. There's been learning for sure. There's also been reasons for hope and optimism. And so I'm going to begin with Dr. Van Alphen and ask you if you could share a few thoughts with us on why we should be optimistic.
I am optimistic because first of all, yes, a lot of women unfortunately out of the workforce, but a lot of women are still in the workforce and a lot of people are back in the workforce. There is traffic out there. I'm not happy about traffic, but that means people are back working. So whether are the measures that we took, whether there were some later or earlier, whether it's the vaccination or whether it's ongoing education and relentless work to provide support for our people's safety in their lives, it is working. And the best example is my daughter, who is 4 years old now. She started daycare last year in 2020 in July. No one was vaccinated. All they had was a mask. Of course, no fatalities, but no one had, so only one kid has tested positive in a year and a half. So if we forget everything, masks are here to stay, I hope, for a long time, especially in the indoor environments. And yes, as science continues to work in figuring out variants and in figuring out other vaccinations, though I'm pretty happy with what we have, and hopefully we can provide for children who are under the age of 12. I think that just keeping back to the basics, we know we can be safe, and we know that the next pandemic, we might not need to go into a lockdown. Just some very simple tricks will support us while science does their job in figuring out the next vaccine.
Wonderful. Thank you for that, Dr. Van Alphen. Chris, what about you? Why should we be optimistic?
Everything that was just said is perfect, actually. If you're looking for the future, I think that we've learned a lot in our past. And just to bring it forward, I think that we're not going to make some of the same mistakes that we did because we weren't perfect. No one's perfect. So I think that we can learn from our mistakes. And I think we should be very optimistic because I don't want to say be negative on this, but COVID's going to go anywhere shortly. You know, I think that there's always going to be something out there and we have to be prepared.
That's right. That's right. Thank you, Chris. Representative Gouveia, I'm going to give you the last word. You can either shout out a reason to be optimistic. You kind of gave us a preview of that, or you can point us to good sources of information for people who may have questions on the pandemic.
Yeah, I think I'll end with 3 things. So people know what public health is and understand that it's really so critical to invest in. Our mental health, people are really much more conversant and comfortable talking about mental health challenges, the need for mental health support. So I do hope that we see reinvestments there. And then the other thing is, looking at some of the changes that some restaurants have made around the ways that they pay their staff. We know that women are underpaid when it comes to the service industry because they rely on tips. That opens them up to sexual harassment oftentimes. And so hopefully seeing us get one fair wage on the state is also something that might come out of the pandemic, so that women are paid equitably for the great work that they perform every single day.
Great, thank you. Dawn, I see you're back on camera. Do you want to take us home here?
Okay, I want to say a few things about the basics before we go. We need more women in office. So I would just encourage everybody who's on this call to check out our website. Tomorrow, we're going to do an event with Cape Cod Coalition about getting more women to run for municipal office. And we have a training course on Thursday about fundraising, which is free and open to the public. And just consider joining Representative Gouveia at the State House. She needs more allies. I think Christina and Magnola should be running for office. I know they're busy,
Yes.
but I nominate them. So, we always say it only takes 7 times before a woman will consider running. So you two, you've been asked, okay? All right. I want to thank everybody for coming, and we will see you very soon.
Great. Thank you, everybody. Thanks for our wonderful panelists. Have a wonderful afternoon.
Thank you so much.
Thank you.
Take care.
Well, thank you.
Done. Oh, let me turn off the recording.
Yeah. Okay. Susan's really good at this.